Yes. Okay, thank you again for having us today. And yes, stroke is my passion, but as I have told many people, it doesn't matter what job that I would have, that would be my passion. So if toenail fungus was the job that I was given, that would be my passion as well. And I would be here probably presenting about that. But today we are trying to raise the awareness of the need for early stroke care when a patient has a stroke. And so I will introduce to you Lisa Shannels, and Mike is her husband. And Lisa is the reason that we are working so hard. She is the perfect example of why we are working so hard to get the awareness out there, change the processes that we have, and get the education to everyone that stroke is a time-sensitive medical diagnosis that people need to hurry into the emergency room. So, Lisa, I would like to...
Okay, well, I'm here to tell my story, and it starts with teaching. I'm a high school biology teacher. That's what I've been doing for 23 years. And for the last 20 years at least, I have been teaching physiology and anatomy as part of the curriculum. And every year there's one day where I tell students, this is the day I want you to remember. You can forget the rest of the days, but cardiovascular disease is the leading cause of death for men and women, and these are the symptoms. So this is what I want you to remember, because everyone knows someone who's had a heart attack or a stroke. Well, that was me. November 29th, I went to bed the Saturday after Thanksgiving, and my oldest son, Nick, was out with friends. Mike and my youngest son, Tommy, were downstairs still watching TV. I went up to read, and I brought my phone with me, and I never do that, but Nick was out, and if he called, I wanted to be able to talk to him, see what he was up to.
Tell him to come home.
Tell him to come home, yeah. No, you can't stay on after curfew. Yeah. And I was reading The Emperor of All Maladies, which is about cancer. Had the book propped up on my legs. I was, snuggled in to read for an hour. I love to read. And first symptom was overwhelming tiredness. I didn't even want to turn off the light. I thought that was kind of strange as my vision got a little blurry. That's really strange. Then my tongue got tingly, and I just felt like I was ticking through that list of symptoms. My hand slipped on the right side, my leg kind of sagged, or knees sagged against each other, and I yelled for Mike, and my voice didn't project. So, and I thought, I'm having a stroke. And looked at my phone, reached over to get it, couldn't do that, so I tried to sit up with my left side and then ended up sliding off the bed. But there's that emergency button on the lower left-hand side, and I used it. And luckily, the 911 operator just asked yes or no questions. But I said I'm having a stroke, and it goes from there. She asked if I was at 685 Franklin. Yes. Is anyone home? No. Oh, yes. Do they know you're having a stroke? No. They're downstairs. And while we're talking, I'm thinking, I can't be having a stroke. I had a checkup last month, and I've got great cholesterol. really low. My blood pressure is really low, so it can't be ischemic, it can't be ischemic, but, you know, I know something's strange. I don't know what it can be. The emergency team gets there, and I tell them, well, you know, they go through all the blood pressure pulse and ask me if I'm taking drugs, because that's the leading cause of stroke. I didn't know that. And I told them they're wasting time, that I wanted to get to the hospital to get that TPA. And I had read somewhere, maybe in Discover magazine, Scientific American, that, so I knew about TPA. And also, I had read My Stroke of Insight a few years ago. It's by a neurologist, Jill Taylor, and it's her story of her kind of diagnosing herself as she's having a stroke and trying to call, not being able to remember the phone number of 911. And I thought of her as I was calling 911. I have to do what she did. So I was in a unique position to know all these things, and that's what I think got me through it and kept me calm during the process. The other book I had read was The Brain That Fixes Itself, and that's all about brain plasticity. So I thought, all I have to do is get to the hospital, get this done, get this fixed, and then rehab, and everything will be okay. Just like that. Yeah. And you know, I know I got really lucky. I had a really good medical care, and because of this stroke program, I understand that that's why I got TPA in Muskegon County, that until 2013, the drug wasn't administered regularly. So thank you for the stroke education in the ERs, because I think that saved my life.
Awesome.
Yeah.
Thank you.
Thank you.
So we'll start with the PowerPoint. And there are two types of stroke, ischemic and hemorrhagic. Ischemic stroke is where you have a blood clot that stops the flow of blood, and it will cause ischemia. Hemorrhagic is where you have a vessel that will break and bleed into the brain, and the same symptoms. Stroke is the fourth leading cause of death in the United States. It used to be the third leading cause, but really because of the big push of all of education about stroke, and they feel that that has helped decrease it to number 4. More than 140,000 people die each year from stroke, 795,000 strokes per year. And in Muskegon County, we're one of the unhealthiest counties in Michigan. So we have a huge need to be aware of this. 55,000 more women than men have a stroke each year, and stroke kills twice as many women than breast cancer each year. And these are just some of the risk factors. So the ones on the left side are things that we cannot change or control. The ones on the right side are things that we can control, and 80% of strokes can be preventable. So again, raising the level of awareness and education to the community, to patients, to everyone, they can help reduce their risk for stroke by controlling these risk factors. Every minute of ischemia, you lose 1.9 million neurons. So every hour of ischemia, 120 million neurons. It's like aging the brain by 3.6 years. So 10 hours of ischemia would be 36 years of aging for a brain. And I don't think any one of us wants to lose 3.6 years at all. Some of our statistics. So here at Mercy Health, we have between 500 and 600 stroke patients a year. In the year 2013, we had 3 patients that received TPA. And after going to the International Stroke Conference and getting education and working with St. Mary's and coming back and really pushing emergency physicians to be aware of how they can help, we gave 37 doses. 18 of those were at the Hackley campus, 18 were at the Mercy campus, and 1 was at the Lakeshore campus. So they've really done their part as emergency room physicians in becoming educated. And I'll let you speak to that a little bit because you are one. And
So this is, I didn't know there was going to be a camera.
Practice for free.
And this is going to be, you're my guinea pigs because somehow I can't say no and I've volunteered to do take 5 on Friday morning. And I found out you don't get a dry run, so I guess this is my dry run. And given you're all clinical people, first thing, well, a lot of you are clinical people. So how many of you, if you were having a stroke, would want TPA? Or clinical folks? So do you all know the benefits?
No.
What are the statistics?
You still have to give it within 4 hours of symptoms start.
Okay, so time is a big factor. The longer you wait, the less likely you are to benefit, the more likely you are to do harm. So this is one of the issues that we have as an emergency physician. If you come in with a stroke, how do I explain to somebody who's in the midst of some potentially catastrophic event so that it makes sense to them, because this drug is not without risk. You all know, especially people who are nurses, it can make you bleed in your head. So when I talk to these folks, I've got to try to get informed consent, which means I have to give them an idea of what's the likelihood that this is going to benefit me versus harm. And what are the things that most people are concerned about when they have a stroke? What would you be concerned about? So what are you trying to avoid? Besides death. Okay, so it's dependency, right? I mean, everybody wants to be independent. So when you look at what the outcomes are that we're looking at, it's are you dependent? Are you independent? Can you take care of yourself? Is somebody going to have to take care of you
do you want to go
in
to
the future? So, yeah, I want to go forward. So in terms of looking at those issues, TPA is obviously what people would call the clot buster. It breaks apart clots, and clots are what cause ischemic strokes. And Becky alluded to the fact that there's ischemic strokes and bleeding strokes. And ischemic strokes are about 8 out of 10 or 80% of strokes are ischemic and 20% are hemorrhagic. If you have a hemorrhagic stroke, you are not a candidate for this drug. It will kill you, okay? So that's number one. So that means what do we have to do when you come in? We have to make sure with a study, with a test, that you're not bleeding. And we use a CAT scan to identify those patients that are having an ischemic versus a hemorrhagic stroke. As far as the risk-benefit, the biggest study, the most famous trial that came out was the NIN study. And the NIN study, it's over 10 years old now. And it took patients who were 0 to 3 hours into their stroke. In other words, the one thing we really need to get a beat on when you come in the ER is when were you last known well. So we know when the onset was of your stroke, because then we can time how far you are into it. So if you wake up with a stroke and you went to bed at 11 o'clock at night and you wake up at 7, you are not a candidate, because we don't know when it started. It could have started at 11 at night, and you could be 7, 8 hours into your stroke. So we have to figure out the last time you were known well. So the NIN study took patients who were 0 to 3 hours from last known well, and they gave those patients TPA, and there were other factors, but basically the benefit comes at 3 months, and 3 months is and they use something called the modified Rankin scale. The modified Rankin scale kind of is a scale to measure how much disability you have. And 0 to 1 means you can take care of yourself, which is what's important to you. When you're at, I think the top number is 5 or 6, that's dead. Okay, so you're somewhere between being able to take care of yourself and dead. But 0 to 1 is what you want. I want to be able to take care of myself when I'm done. So the NINS trial showed that patients that were candidates 0 to 3 hours from last known well, the benefit was 38%, 0 to 1 on a modified Rankin scale versus 21%. It's not a magic bullet. It's an improvement. Yeah, so, 21 versus 38 out of 100 will be independent. What's the cost that you pay for that? If you don't get TPA, strokes, some of them convert, they call it. They transform from ischemic to hemorrhagic just with time. Your first CAT scan is negative, and 2 days later you get worse and you've hemorrhaged without TPA. The risk of that happening is 0.6% without anything. If you give TPA, the risk of a hemorrhagic transformation is 6.4%. So it goes up times 10. And half of the patients that bleed will die. Okay? So there is a risk to this drug. There's no overall mortality benefit. In other words, the patients that die from the drug are balanced by the patients that die from the severity of their stroke. The benefit is you're functioning at the end of 3 months, so you have a higher chance. So that's the way I try to explain. What I tell patients is, if I have 100 patients who come in with a stroke, all comers, 25 will leave the hospital relatively independent. If I give you this drug, that'll increase your chance to 35%. 35 out of 100. What is the risk? Less than 1% chance you'll bleed in your head. You'll increase that to 6%, and you could die. I think that's a fair representation of the risk benefit. And most people say, give me the drug. Because I think and I think about that, it's not like giving an aspirin to a heart attack patient where there's almost all benefit, no risk. I don't think people want to be dependent. They want to be able to take care of themselves, and that's why they accept that. The other big trial was the ECAS trial, and that was looking at patients who were 3 to 4.5 hours from last known well, so they even extended the window up to 4.5 hours. The benefit isn't as large. It's from 45% full recovery to 52%. I don't know why the bleeding rate was so low in that study. I really don't. That's curious to me that it was only up to 2.2%. So basically, time is a huge issue in stroke care, in being able to intervene. The benefit, if you can intervene early, is way up here, and as time goes on, you lose that benefit, and when you get out to 8 hours, so the big push here is education to the public about what symptoms, signs to look for that you're having a stroke, and number two, if you're having that, get to the hospital, because we've got a lot of things to do. Next slide. This just gives, we talk about how many neurons and how many years you lose. I think this is more impactful in terms of what people want to know. If you're going to look at the benefit of opening the clot up, every 15 minutes that you can decrease your time from last known well to getting the drug, if you have a clot, increases your odds of being able to walk independently by 4%. Increases your odds of being discharged home instead of to a nursing home by 3%. Decreased risk of death by 4%, that's years out from the complications of stroke. And decreased risk of hemorrhage by 4%. The longer you wait for damage to occur, the more damage those vessels get, the more likely when you give the drug you're going to bleed. So it's not only benefit, you're also, by decreasing that window, you're reducing your risk of harm. So, does that make sense to everybody? When you come into the ER, what are our challenges? The first one is that some things can mimic strokes. They look like strokes, you're not having a stroke. And I have a large group of nurses in here, what sort of things would you think about might mimic a stroke? Can you think of any?
Syncopal episodes.
Okay, so syncopal, if you ended up
Passing out
yeah.
for one reason or another.
Focal, but if you came in with something focal, low blood sugar can cause people to look like they're having a stroke. So we always have to measure a blood sugar right away. What else? If you have a seizure, some people after a seizure will have a focal deficit that's from the seizure, from the area of the brain that sees, doesn't work so well. And that's called Todd's paralysis. How about MS? Anybody know anybody that has MS? So there are things, brain tumors. A brain tumor could, although usually symptoms are slower in onset. So there are stroke mimics, so that's number one. You don't want to give somebody that drug if you've got something where you've got no chance of benefit and all the risk of bleeding. When we get people in there, I already talked about the fact that we have to try to figure out last known well, and that can be a challenge sometimes. I mean, patients come in, they can't speak, so you have to wait for family members, so we've tried to educate all our paramedics. If you can get that information at the scene and bring it to me, otherwise I might have to wait a half an hour for family to get in, for a patient who can't speak or has garbled speech to get that key piece of information. We need a CAT scan of the head to make sure you haven't bled. And that's been a huge change in our process in Muskegon. Used to be that patients came into a room and they got all this, blood pressure and got in a gown, did a neuro exam, and then after a while we got them to CAT scan. It was a huge shift in thinking that you take these people and we screen them with a tool called FAST, and we'll go over that in a minute. But if you screen positive, you go right to CAT scan. As long as you've got an airway, you got a pulse, you got a blood pressure, you're going right to CAT scan. So we can get that key piece of information right away. And Ann's worked on that with us, and we've gotten, I think, a lot of buy-in from the ERs, from radiology, from your techs. I mean, that this is what we're doing here in town to try to save time. The NIH stroke scale, that's a scale that we use to measure how bad is your stroke. It gives you a certain number of points for different deficits. And it's fairly complicated as far as, learning that scale. So educating not just the ER staff, the ICU staff, the nurses on the floor, because if you get that drug, we want to know if you're improving or not improving, because if you're not improving and you're actually getting worse, you have to think that you could be bleeding in your head. And we use that scale to determine when you might get another CAT scan to look for that. So educating all the staff to use that scale the same, because if the ER nurse gets a score of 15 and the same patient goes up to the ICU and that nurse gets 18, the higher the number, the worse your stroke. But they're seeing the same thing, but they just apply the scale a little differently. Suddenly that patient might get a CAT scan because they're doing the scoring a little bit different. So you've got a huge educational undertaking across the system to make sure everybody's doing that stroke scale the same way.
How many times did they test you, hon? Every person that came in, every time, it seemed like
Yeah.
went through that whole thing.
You were it started in the ER, I hope.
Yeah, yep.
And it's so you're using a consistent tool to measure how bad you are so that you know, is somebody getting better? Are they getting worse? And it sounds simple. Well, it's not simple. I can tell you that you'll look at the same patient and have 2 or 3 people look at the same patient and get a different score just because you measure something different. And
A lot of times they would confer about.
that's a warm handoff, we
Scale.
call it, where the 2 providers, and when you're having a handoff, like you're being transferred from the ER to the ICU to a step-down unit, the 2 providers that are taking, usually nurses taking care of you, will do the scoring together at the handoff time so you see how you scored it so you're not scoring it differently. Was that what you experienced? That they would do it
Quite a
together?
bit, yeah.
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 So, this is the biggest challenge. Since time is a huge factor, only 22% of stroke patients present to the ED within 3 hours, and 8% meet criteria for TPA because people wait. And we have an educated patient here who knew,
10, 11.
huh?
It was 10, 11.
Who knew that was, yes. You said,
Sit home and, this is gonna pass.
well, that's our natural tendency, is denial. This can't, and especially a young person who exercises, has low cholesterol, doesn't have any risk factors, your first thing is this can't, even if you know what a stroke is, my first thought would be this can't be a stroke. And so you sit at home and you wait and you wait, and by the time you come in, you're out of the window to do anything. So our biggest challenge is to get that sort of a message out to the community. We have a huge number of stroke patients in Muskegon County, We have a huge burden of hypertension, diabetes. We still have a lot of people who smoke, obesity. These are all the risk factors for strokes. We have, St. Mary's has a huge neuroscience center, the Howenstein. We have, at least as of last year, we had double the number of strokes in Muskegon that they do at St. Mary's. Now theirs has climbed a little because they've got more referrals, but we have more strokes here in Muskegon County than they do at St. Mary's. I'm not saying Grand Rapids, you understand there's other hospitals there. Okay. There's been some exciting new trials that have come out since January of this year, and I'll just mention one. It's the Mr. Clean trial, and the reason I'll mention it is because it was done in the Netherlands, and I'm Dutch, and it was all Dutch people who did it. But for years they've been looking at, if any of you know that heart attack or cardiac care, acute MI care used to be you couldn't do much, and then we went to reducing fructokinase, and then it was TPA, and then we started taking them to the cath lab to do stents and balloons and open up arteries. And it's like, why don't we do that with strokes? Well, they've been looking at that for a number of years, and there's actually 4 trials now, and I don't know all the particulars why suddenly these trials are showing improved outcomes. The instruments have changed, they've gotten better in being able to get up into the vessels, but now there's 4 trials that came out since January. The Mr. Clean trial, Swift Prime trial, Extend trial, I don't remember the other one. There's 4 of them. They've all shown the same thing. A couple of them have been stopped early. If you can get up into that vessel, if you have a large vessel occluded and you can get up there and pull the clot out, there's improved outcomes, even better than best medical management, which is TPA. Again, the challenge is you have to get them there and get up into that vessel and get the clot out 0 to 6 hours from last known well. We have 1 neurointerventionalist at St. Mary's, we have none here, so our challenge will be to get somebody into the hospital, get a CAT scan, okay, that show no bleed. Then we have to get a CAT scan, if they have no bleed with dye, to look at the arteries. And then we have to identify whether they have a large vessel clot, and then we have to transfer them to Grand Rapids and get them in a lab, and the groin, get a poke in their groin and get the catheter up into that vessel and pull it out 0 to 6 hours from last known well. That's going to take a huge amount of coordination of processes to be able to achieve that. What's the best way to be able to improve our chances is to get in early. So we have the full 5 hours. If you come in an hour into your stroke, I got 5 hours to work on getting that all done. If you come in 4 hours, I'm probably not going to be able to do that. So, and the Mr. Clean trial showed that 1/5 to 1/3, the patients that got best medical management, minimal to no disability were 1/5, and the ones who got the neurointervention or the intravascular intervention where they pulled the clot out 1/3. So it's a huge improvement in outcome. And again, the challenges I outlined, it's a CT, CTA, and transportation. So I guess our biggest ask is education. It's education for the public, especially given our community has such high stroke rates and high rates of risk factors for stroke that patients know what they look for. I skipped over FAST. I don't think we have a slide for FAST.
No.
It'll be on take 5, so.
No, but
FAST is the facial droop. So if your face is drooped, arm drifts. So if people put their arm out and it drifts, arm weakness, speech difficulty, garbled speech, and T is for time. Time is fast. And that's what we use for paramedics. That's what we use for triage nurses. That's what we're starting to push out across the system for nurses in the hospital. If they have a patient, you can have a stroke while you're in the hospital.
Yeah.
And actually, the chances you'll get the care you need if you're in a hospital bed are less than if you're out and come into the ER. And it seems counterintuitive, but the people in the hospital are not yet, the inpatient process to identify these people and get them through this process are not as well develop when you're in the hospital as they are in the ER. That's another thing we need to roll out. Educate the staff about FAST, how to do an NIH stroke scale, how to get them the CAT scan. So there's huge educational opportunities not only for the public but also for the staff in the hospital that these funds could be used to get those things done. So.
One of the other things that we would like to do is open or have stroke health screenings, like the heart health athlete screenings, to have free screenings like carotid Dopplers, get their cholesterol done, blood sugar checks, blood pressure checks, to see if they're at a higher risk for stroke. And there's a, on this next slide, on the right is a risk scorecard. So this is developed from the National Stroke Association. Having something like this and having primary care offices have these tools, and if they have a patient that they think is a risk for stroke, doing this and seeing where their patient stratifies and then making sure that they're getting treatment or following up or getting the education to change those risk factors that could cause a stroke. On the left, Kelly helped design. This is a FAST magnet. I've given you all a packet. In the packet is some of the information that we give patients when they're discharged. And currently we do not have some of our own printed materials for stroke, so the FAST magnet in there is provided by Genentech, and I like ours better, so we did get a quote. We are going to have some printed up. It's roughly about over $1,000 for 5,000 magnets, and they won't go far. I mean, we give one to every patient when they're discharged. Some things that I have thought about getting education out into the community, maybe working with local pharmacies, physician offices, having something branded that we could, if they get an antihypertensive medication or cholesterol medication or diabetes medication, they can get something branded that has that FAST information, so they're getting the education on knowing that they need to get in fast because they're at risk for a stroke if they have any of those symptoms. You know, we have these current folders. It would be nice to have Mercy Health folders to put all of our education in to give the patient to go home with. It just looks a little bit more professional. It looks nicer. But we are limited with our funds that we currently have. Education for staff, it's been just a couple of people getting out into every department, and the nurses in all of the departments really want education. I listed a sign-up sheet if anybody was interested in certified stroke nurse classes. I had over 160 people sign up in just 6 areas of the hospital to want to do that. The research shows that if you have a designated stroke unit, your patients have better outcomes, and those designated units, having nurses that are educated and know how to take care of those stroke patients will get them the better care to give them the better outcomes. So we have designated a couple of units at the hospital. North 3 at Hackley has been designated as their stroke unit, and at Mercy, Fort East has been designated as their stroke unit. So working with them, the certified stroke nurse classes, in order to take one, it's about $325 per nurse, and the test is $385. And we kind of feel, since this has been such a great initiative and there are so many people that are interested in wanting the education, we really need to provide this. We want to do this for our patients. And so we are going to continue on. We will go to a couple classes, an educator and myself, and we will go learn how they teach, because it is too expensive to have classes brought in continuously. It's about $6,000 for one class to be brought in, and we just felt if we go to learn the education ourselves and develop our own teaching plan, we can continually teach to many, many people. So we're cost effective. We try to use our money wisely, and for Nurses Week and National Stroke Awareness Month, we bought every nurse this little NIH stroke scale book, and it's a pocket guide. They love them, but I've had SHM, which is the internal medicine group at the hospital, ask if they could have them for their group. We've had the ER doctors asking if they can have them. The residents, the medical students, they all want them so they know how to do it. Pharmacists have asked me if they can have them. And, you know, I think education, everybody deserves to have the education. If they want to utilize that, they should have that education. And if they're impacting the patient in some way, we should reach out and give them the education. So, you know, I just really feel like it's very nice of you to ask us to come and give this presentation. We really don't know exactly what it is we really need because it's so new, and we just know we need many things to continue with the stroke program, and we've come drastic miles with what we've done so far. The staff has been very appreciative. They're very on board at the hospital. Everybody is talking about it. We have a stroke committee meeting every month, and there's probably 25 people every month that come to the stroke committee meeting, physicians, nursing staff, managers, directors. The CNO comes. We just all really are working hard to make an impact on the stroke patients. We need to get into the primary care offices. There are just so many avenues that we can take with education to get out to the public. Having printed materials, we could have them in hopefully grocery stores, you know, out to the general public so they know the importance of getting in when they have those symptoms of facial droop, arm drift, or slurred speech, and the importance of timing. And then just anywhere we can have our materials to spread the word will help more and more people come in a timely, life-saving, you know, so it's important. And Lisa's the perfect example. We recently gave TPA to a 98-year-old lady, and she was discharged, and the staff was really impressed